of commerce. MMAC envisions a globally competitive region that fosters high-value employment to sustain a vibrant quality of life for all. With 2020 in the rearview mirror, I think we've all gained a better understanding of what FDR meant when he said, "A smooth sea never made a skilled sailor." So I'm not ready to say 2021 will be smooth sailing. We are ready to turn the page on our webinar series, Business Strategies During the Pandemic. So welcome to the first edition of the Business of Milwaukee. This monthly webinar will do just that, provide a timely and forward-looking focus on the business of Greater Milwaukee. We hope this series will bring you unique insights to you, to your business, and to the challenges and opportunities we face in sustaining and growing the region's prosperities. One of the key factors in Milwaukee's rebounding economy is managing the spread of COVID and how we continue to keep our customers and our employees safe, and what the future impact and rollout of the vaccine will mean to this progress. So we're again grateful to have Dr. John Raymond, president of the Medical College of Wisconsin, as our guest, along with his colleague, Dr. Riccardo Colella, professor of emergency medicine, pediatrics, and the Institute for Health and Equity, to discuss what business leaders need to know about the latest COVID developments, the vaccine rollout, and to answer your questions. But first, before we get to Dr. Raymond, a word from our sponsor. Today's program is sponsored by United Healthcare. In times like these, a traditional health plan may not be the best fit for your business. So take a closer look at the All Savers alternate funding from United Healthcare. MMAC partnered with United Healthcare to offer coverage for groups between 5 and 99 employees. Now small businesses can take advantage of the benefits typically reserved for large companies, including underwriting for more competitive pricing, better data so your business understands where your premium dollars are going, and a potential surplus refund if claims are lower than expected. So contact your MMAC broker or visit uhc.com/MMAC to learn more. So Dr. Raymond, as our first kickoff to 2021, let's get an update from you on where we are with COVID, and then we'll take a look at the rollout of vaccines and what that means to the region.
Yeah, thanks so much, Tim, and welcome to 2021, everybody. If I could go to the next slide. And I want to point out on that previous slide that we have a new analyst, Ali Namadi, who will be helping to assemble these presentations. And want to thank the MCW Institute for Health and Equity for always being there to help us with analytics. And next slide, please. So I'll get to the numbers. 2.9 million people have been tested for COVID-19 in Wisconsin since the beginning of the pandemic, and that's half of our population has been tested at least once for COVID-19. Of those, a little over 500,000 have tested positive, meaning that about 1 in 12 people in Wisconsin has had COVID-19 as diagnosed by the polymerase chain reaction test. Similar numbers in Milwaukee when you compare the size of our population, about 464,000 tested, 89,000 positive since the beginning of the pandemic. We had a light reporting day yesterday. It's hard to believe that we would call these numbers light compared to what we were seeing in the summer, but certainly compared to our surge in November, these are light numbers. So 1,456 in Wisconsin, 218 in Milwaukee. Our case positivity rate remains high, and you can see the numbers yesterday were 26.7% and 25.1%, and that the 7-day averages are over 30% positivity. What that means is we're probably not testing enough people. There are a variety of reasons for that, but it also means that there's a significant burden of undiagnosed disease in our community. Probably most of those folks have mild symptoms or no symptoms. Next slide, please. Just in terms of hospitalizations, we've had over 22,000 people hospitalized in Wisconsin with COVID-19 since the beginning of the pandemic. The likelihood of being admitted to the hospital if you have a positive diagnosis continues to trend downward. It's at 4.4% probably because we've learned a lot about how to take care of patients with COVID-19. Testing's more available, and we have some moderately effective therapeutics. Inpatients are trending downward from a peak of 2,277 in mid-November to 1,017 yesterday. And Sunday, we actually dipped below 1,000 at 999. Our week-over-week trends also are favorable, down 105 patients from last Monday. ICU patients also are trending favorably, now with 221 in intensive care units. That's down 10 week over week and from a previous high of 456 in mid-November. ICU capacity is okay, not great, but better than it was in November. We have 261 beds available in Wisconsin for ICU beds available for people with or without COVID-19. We'd like to see those numbers increase. Ventilator capacity is fine, 1,915. And as I've said before, ventilators will not be a limiting factor in our ability to take care of patients with COVID-19 if there's another surge, or patients that don't have COVID-19. And as you might expect, our personal protective equipment stockpiles are somewhat depleted because of the surge that we experienced in October, November, and early December. But those trends are stabilizing. The most current needs are gowns, goggles, and paper masks. Next slide, please. Thank you, Chris. Also, just as indicative of having recovered somewhat from that huge surge in late October and mid-November, we have 93.4% of patients diagnosed with COVID-19 who are categorized as recovered. And what that means is either resolution of most of their symptoms or being 30 days out from their diagnosis confirmed by PCR. And again, as I pointed out in the past, up to a third of patients who've had COVID-19 continue to suffer from residual symptoms, and they have not returned to their pre-infection state of health. So these are the so-called long haulers. Only 5.6% of the cases diagnosed in Wisconsin since the beginning of the pandemic are currently categorized as active. And again, that reflects the downward trend that we've seen, or the deceleration of the surge that we had in October and November. And 1.0% of the patients who've had COVID-19 have died. And that's gone up just a little bit. We were running at about 0.8%, still much better than the average in the US, which is slightly under 2%. You can see that we've exceeded 5,000 deaths in Wisconsin, and we're approaching 1,000 COVID-related deaths in the Milwaukee region. Continues to be a slight male prevalence for deaths as well as infections. And again, a disproportionate representation of people of color. 7.2% of the deaths in Wisconsin are African American or Black, and 26.2% of those in Milwaukee, 6.1% of Hispanic and Latinx in Wisconsin, 13% in Milwaukee. And as I pointed out in the past, early in the pandemic, there was a much higher prevalence of deaths in people and communities of color. As the pandemic spread through the predominantly white rural regions of the state, the numbers for whites increased significantly. And that's a trend that actually still is continuing. I want to shift to the right-hand side of the slide and talk a little bit about some indicators that are trending favorably and some that are not. So in terms of our doubling times, those are lengthening in Wisconsin and in Milwaukee. So that would be a favorable trend. But remember, the doubling times when you've had 500,000 positive cases really still means you have a high burden of disease. So what that means is in Wisconsin, 50 days from now, we'll have another 500,000 cases. Again, the 7-day growth rate is improving, it's decreasing. A lower number is better. But again, when you're talking about a burden of 500,000 cases, the 7-day growth rate still is pretty significant. And I think one number that I really want to highlight is the reproductive number is over 1 again, which is unfavorable. It says stable mainly because that number has been significantly above 1 for the last 10 days. And although I'm not showing you the trajectory plots today, our deceleration of the pandemic stopped about 10 days ago. and we're starting to see an upward trajectory, the sawtooth configuration that I've showed you before, meaning that the progress that we've made seems to be slowing down, may stabilize, and may actually start to worsen in the near future. So the point that I want to make here is that it's critical that we get COVID-19 shots in people's arms, as many people as possible, as soon as we possibly can. The next slide, please. I want to pivot to talking about the vaccines. As you have heard before, there are 2 safe and effective COVID-19 vaccines that are already approved by emergency use authorization for distribution in the US. Those happened in mid-December. And I want to point out that these are both mRNA vaccines. And although they seem to be very safe and quite effective, this is not a particularly mature technology, and the manufacturing capacity for these vaccines is being developed. So we can't simply contract like we would with a more mature technology. And that is a limiting factor for us. We need that manufacturing capacity to ramp up quickly. So no single drug company is going to be able to meet the short-term demand for hundreds of millions of doses in the US. And we need some other manufacturers to come on the market. The sooner, the better. And there are multiple other vaccines in development. Shifting to the right side of the slide, Novavax, AstraZeneca, Oxford, and the Johnson & Johnson vaccines are all very likely to apply for emergency use authorization in the first few months of 2021. And this is important because they use a more mature adenovirus technology that can be ramped up very quickly. If I can go to the next slide, please. Thank you, Chris. Just want to give a summary and also point you to a very valuable source of information. The Wisconsin Department of Health Services started posting information about vaccines in early January. And you can see that Wisconsin has actually been allocated a rather slim number of doses at 420,000 compared to some other states. 267,000 of those doses have been shipped. And I want to point out that that does not mean that they've been received or distributed to the vaccinators. And about 150,000 people have received their first dose of either the Moderna or the Pfizer vaccine in Wisconsin. Now, why are people concerned about what we would call a slow rollout and ramp up of vaccine distribution? First and foremost, I want to say that maybe our expectations were too high. There's been uncertainty about when and how many vaccine doses will actually arrive in Wisconsin, and that remains a continuing concern. So a lack of information that we can deploy to effectively distribute these vaccines. Also, there was a ramp up process that required certification of the hub sites, and MCW was just approved as a hub, and we went through that process. So you have to document that you have adequate and appropriate storage capacities, ultra cold chain capabilities, appropriate chain of custody controls, security issues, and that your personnel are trained to administer the vaccine. There's also a certification process for each individual. Also, you're required to report and track the doses given and those that are wasted. And we needed to make sure that we have access to that reporting system. Also, because if you think about it, looking at the numbers, 267,000 doses shipped. In Wisconsin, we have just short of 500,000 people categorized as 1A. In other words, healthcare providers or people working or living in long-term care facilities. And because we haven't received or have had shipped enough doses to cover that 500,000 number, each organization had to go through a prioritization process to decide who within the 1A categories would get those vaccines first. And so, for example, here at MCW, people working in emergency departments or COVID-19 units or with immunocompromised patients were prioritized as the top priority in 1A compared to other frontline healthcare providers, simply because we had a shortage of doses. Also want to point out logistics issues, storage, accessibility, safety, and post-vaccination observation areas, just in terms of distributing the vaccines. So you can't have a mass vaccine clinic. People need to maintain social distancing, masking, There needs to be a chain of custody. People need to be identified as who they say they are. And because of the concern about serious allergic reactions that developed in December with a few people that had anaphylaxis, you need to observe people for 15 to 30 minutes after they receive the dose. That requires deployment of healthcare personnel who could otherwise be giving the vaccines to watch the people, and it slows your throughput. Now, having said that, I believe that the ramp up is actually going quite well and that we're learning as we go, so that when we go into 1B and then hopefully into phase 1C and phase 2, where we're beginning to vaccinate our communities, we'll be able to do that very effectively. Next slide, please. So again, I just want to circle back. I am concerned that vaccine hesitancy at the end of the day is going to be the largest and most important limiting factor for how quickly we achieve herd immunity and how we can vaccinate our population. I want to point out that these two vaccines, even though they were developed very quickly, have shown every indication of being very safe. And these vaccines are the swiftest way that we can end the pandemic and resume some semblance of normalcy. And the safety and effectiveness of the vaccines are consistently being tracked. When there is a concern like anaphylaxis, that is reported very quickly and analyzed. And I do want to point out that only 11 out of 1 million people so far seem to have had an anaphylactic reaction to the vaccine. So this would be what we would call an uncommon or rare side effect, but still it's significant. And I want to assure everybody that the people administering the vaccines are taking appropriate precautions, for example, by stocking epinephrine and steroids that they can give to treat an anaphylactic reaction. And that's why we have the 15 to 30 minute observation period. Now that may cause challenges if we want to set up drive-through clinics, if we're still going to continue to monitor people. And that's something that we're going to evaluate going forward. Also, I want to point out that these vaccines have been shown to be effective for diverse ethnic groups, every adult age group over 18, and for people with coexisting morbidities. There haven't been comprehensive testing studies yet on pregnant women or children. And I would point out that ACOG, which is a large specialty group, has actually recommended that pregnant women and lactating women do receive the COVID-19 vaccines under the observation of their primary care provider. If I can go to the next slide, please. Just want to make sure everyone level sets about who is in these categories. The federal government has an advisory committee called the ACIP that has developed these categories, phase 1A, B, C, and 2. The state also has a committee called the SDMAC, or the State Disaster Medical Advisory Committee, that uses these guidelines and then refines them for Wisconsin. So phase 1A, as I mentioned, is first responders, frontline essential workers, and residents and employees of long-term care facilities. In Wisconsin, that's about 500,000 people. In the US, 21 million. Phase 1B then would be frontline essential workers and those over the age of 75 who are more likely to have adverse impact of COVID-19. In the US, that's another 49 million people. And let me just acknowledge upfront that some states like Texas and Florida have received enough vaccine that they moved right into 1C and have been setting up clinics to administer vaccines to people 65 and older. Wisconsin simply isn't in the same position to do that because we've not received enough vaccine to immunize everybody in phase 1A, but we hope to be moving to phase B optimistically by the end of January. And again, our goal is to get jabs in as many arms as possible, as quickly as possible. If we have confidence in the supply chain, if we believe that Moderna and Pfizer are ramping up their manufacturing capacity, that the supply chain issues have been resolved, it probably makes sense for us to move quickly to phase 1B, and there are many people advocating for that. And then phase 2 would be all adults, and we hope to be able to do that by the spring or the summer of 2021. And again, the sooner, the better. Next slide, please. Also, I want to point out that, again, you can either look at the Johns Hopkins website. They have a coronavirus vaccine tracker where you can compare progress in various states, or the DHS website from which this screenshot is derived, to look at the number of doses that have been administered on a daily basis. And again, we've administered 151,000 doses in Wisconsin as of yesterday. Now, people have expressed some concern that we're not doing a particularly good job in Wisconsin. I want to say that, first of all, we haven't received per capita the same number of doses as some of the other states have. But despite that, as of January 5th, when the last comparative data were available, we had vaccinated about 1.2% of the population of Wisconsin. And the national average on that day was 1.3%. So we're really in the range of other states. If I could go to the next slide, please. And just finally, just want to show you the data sources that we use for these presentations. We continually expand those, and you'll be seeing the links to the Johns Hopkins website in future presentations. And with that, I'll turn it back over to Tim.
Thanks very much, Dr. Raymond and Dr. Colella. You can jump in, but we've got just a rift of questions. But Dr. Raymond, I just want to emphasize again a point that you made in the presentation when we talk about Wisconsin and where we are. A very interesting point about, our vaccination rate at 1.2% versus the national average at 1.3%. But I just want to emphasize this for all of our listeners. You've made the factual point without suggesting why, but the factual point is Wisconsin is not receiving the same number of doses per capita as other states. And so different states are receiving different amounts of vaccine, not evenly distributed by population. Is that accurate?
Yes, it appears to be accurate, although it looks like, with what I've heard, we're going to be catching up with some of the other states shortly. And to be honest with you, I don't know the reason for it. The legitimate reason could be that we'd already had our surge and we're trending favorably, whereas other states were surging again. Obviously some people have speculated about politics. I would say that this is just probably reflective of the fact that we have not really had a national strategy for the distribution of the vaccines, and that we're sort of learning as we go.
Yeah, so Wisconsin could start to catch up if we get more of the vaccines.
I believe there's preliminary data that would suggest that we're catching up, and we're going to be moving into phase 1B very shortly, maybe within the next few weeks. So that would put us on par with most states, maybe not with Texas and Florida, which seem to receive very large amounts of doses early on, but with other peer states.
Yeah. So has there been any credible explanation determined for the significant surge that was seen in mid-November?
Tim, I wish I could tell you that. We largely avoided the huge surges, the first two surges that many other states experienced. There may have been an element of the holidays. There may have been an element of silent spread through the rural regions of the state, taking hold and then coming back here to southeastern Wisconsin. There may have been an element of pandemic fatigue, or it may just be that it was our time because we didn't have those first two surges. And I think anybody that tells you they know for certain, I don't think that's the case. We're all speculating.
How do we know, or if we know, a better care for COVID patients and now have established a therapeutics in place? Why is the death rate not decreasing?
Again, it's really a good question, and I'm not sure there's a great answer for it, Tim. I would say that the monoclonal antibody therapies, the Lilly therapy and the Regeneron therapy, were very limited in their availability in October and November. They're here now, and many folks simply aren't getting them. And that would be people under the age of 54 with a pre-existing condition early in the course of their disease. I know that the alternate care facility has set a clinic up to make it easy for people to be able to get outpatient treatment there without having COVID-19 positive patients come into the care environment, say for cancer patients. And it really just hasn't taken hold.
And then vaccine available for 65 plus in the vulnerable population. Again, kind of going back to your slide, it just depends about how quickly we move through that rollout schedule.
It does. And again, until we in Wisconsin get assurance that we're going to have 500,000 doses or 500,000 doses, it'll be hard for us to justify going to 1B unless there's vaccine hesitancy amongst that 1A population. And again, we don't want to waste doses. So I do have to say, we have a vaccine clinic at MCW that was stood up by our School of Pharmacy. At the end of the day, if there are 5 or 7 doses left, and we need to get those doses in arms so they're not wasted or spoiled, we have given them to people that are not in the 1A area just to make sure we don't waste the doses. But that's a very small number compared to the 1As.
Yeah, and then can either of you comment on the impact of the policy change, which was talked about, I think, in the Biden administration, and it now sounds like Trump is doing the same. The Trump administration is doing the same thing of releasing kind of all the available vaccine versus delaying some of it for the second dose.
I would say that this makes a lot of sense if we're confident in the manufacturing and distribution capacity of Pfizer and Moderna. And again, what I said is over the last few weeks, I have become more optimistic and have heard many good things about how well they're ramping up. So that I would say, yeah, let's probably get those shots in as many arms as possible as soon as we can. Dr. Colella works on the front line, so maybe he has an opinion that we should hear.
Sure.
Yeah, sure. So certainly, I think these are national strategies that places like the UK are using, essentially giving all vaccines as quickly as possible. And I think Dr. Raymond hit on a point that is important, and that is that there is hesitancy among 1A recipients on receiving vaccines. So there is and there will be more vaccine in the supply chain. So I think while it's important to get all arms jabbed, as the Brits say, I think that the data on the efficacy of the vaccine really centered around 2 doses, at least for these first two vaccines. So as long as we are confident, as Dr. Raymond mentioned, I think it's a good strategy. But the interval time between the first and the second dose should be somewhere around 21 days. The outer limit of that, really is pretty speculative right now. So, I think we're trying to do the best we can with limited data.
Yeah. So if you've tested positive for COVID, is the recommendation to wait 60 days before getting a vaccine?
Tim, what I've heard is 3 months from diagnosis. And that makes sense just in terms of what we know about the antibody response that people get when they're infected with COVID-19, and then how long it takes to develop the memory, T and B cell memory.
That and that certainly makes sense from the immune response. I think the ACIP's guidelines on that actually don't really. So I think in decisions when you have to ration vaccine, so somebody who just had COVID versus someone not, and you have 1 dose of vaccine, then the preference would be to vaccinate the person who was not recently infected because they will have no antibody, as opposed to somebody who was recently infected. So, it makes sense to, if you have to, as a rationing strategy, but I think the guidelines are trying to really get as many people, whether you're COVID positive or not, to be vaccinated. I think it's an important message.
Yeah, Riccardo, I think you made a really important point, and it's something that we need to stress. There are no absolutes when it comes to COVID-19. We're learning as we go, and what seems to be the right and good policy now may change based on new knowledge or the availability of a therapeutic or a vaccine that's in limited supply now and maybe is in surplus 6 months from now.
Are there any new vaccines coming out that are one-shot vaccines?
Johnson & Johnson is testing a one-shot vaccine, and they were supposed to apply for emergency use authorization sometime in January. I'm not optimistic, and there hasn't been much in the news about it, but I did notice that Johnson & Johnson opened a study arm where they're giving a second dose. So that tells me that they may not have been satisfied with the percentage immunity that they received in their early clinical trials, but they haven't released that information publicly. That's the only one I'm aware of. I know Novavax and AstraZeneca Oxford are both two jab vaccines. And those are two of the three that are likely to come to market in the next couple of months.
Questions about the UK variant spreading, and now that's not the only variant now, but thoughts about these different variations of the of COVID spreading. And you made an interesting point in a previous conversation you and I had, Dr. Raymond, that it is not the goal of COVID to kill its host.
Right. And Dr. Colella may want to weigh in here, but there are now 3 strains that are getting a lot of press that are thought to be more contagious because there's a mutation in the spike protein, which is what the virus uses to attach to human cells and then invade them, that makes the virus more contagious. And those are the South African strain, the UK strain, which has been detected in many states in the US now, and what's being called a new USA strain. Let me just start by saying viruses mutate. That's what they do to gain a competitive advantage. That's why we have different flu shots every year, because the influenza virus mutates naturally. The COVID-19 virus seems to mutate a little bit slower than the flu virus does. But the more people that get infected, the more opportunities the COVID-19 virus has to mutate. And as Tim said, it doesn't make sense for the virus to kill its host. So fortunately, none of these 3 mutations appear to be more lethal or to cause more severe illness, but they make the virus more contagious. And so I do want to get to another question in the chat box here about, will the mask requirements be lifted once everybody's received an immunization? First of all, until we have achieved herd immunity, which is probably 70+% of people getting immunized, we're going to need to wear masks. And we have to be prepared for strains that are more easily transmitted or more contagious. And so we might even need to wear masks episodically after we achieve herd immunity. And I'd be interested in hearing Dr. Colella's perspective on that.
Yeah, I agree wholeheartedly. The vaccine is not going to be the end of all the other isolation and distancing, environmental engineering, all the things that we have to do. So I believe that. And actually, one more point about the mutations, in that while it is more infectious, it looks like there is not a decline in efficacy of the vaccine from what I've seen very early. So I think right now the vaccine still is the best option to help to mitigate transmission, and our best option to try to get as much herd immunity as we can.
Yeah, and again, I think you've answered a lot of these questions here about just looking ahead at the rollout of the vaccines as they ramp out, and when does Wisconsin start to get kind of its share of doses, and how fast are those going to get distributed? And I know one question kind of, I think in here was about the timing for pediatric dosing and vaccine availability.
None of the vaccines are recommended for kids yet. There's a little bit of a difference between Moderna and Pfizer. One is recommended for 16 and older, and that's the Pfizer vaccine, and Moderna for 18 and older. And those studies in kids are ongoing now. And I do think it's important that even though children are less likely to have severe complications from COVID-19, they still can get sick and die from it and have long-term side effects. So, we can't ignore the kids. My understanding is that there should be some initial report outs, at least from Pfizer and maybe AstraZeneca, sometime in February or March.
And then a lot of the business audience here is zeroing in on the question of, essential workers, and customer facing. If I'm out, checking gas meters and I've got to be in a home every day. So what are your thoughts, maybe Dr. Colella, on kind of sequencing that?
Sure. Actually, that's in my slide deck if we
Sure.
wanted to use that. Otherwise, we could just off the cuff, whatever is easiest.
Sure. If you want to pull up we'll pull up your slide deck, and
Sure.
that's a good transition into some of your comments.
Perfect. Thank you. And just while we're getting to that last slide, Dr. Raymond and Mr. Shi, thank you for the opportunity to meet with you. I did want to just give you a disclaimer. So, while I am an emergency medicine, EMS, and public health physician at the medical college, I do support DHS in a number of different roles. I'm also on the SDMAC. So my comments today really do not reflect the views of DHS or the SDMAC. So that's my disclosure. Dr. Raymond did a great job of talking about how the FDA gets either drug or vaccine approved, but the translation of that from sort of product ready to get to market to the clinical translation is actually through the work of the ACIP and the CDC. And the ACIP, again, is the advisory committee to the CDC on immunization practice. And the framework that is used to look at how we're going to allocate vaccine is really sort of this triangle. The first one is looking at the science. So basically, what's the disease prevalence and burden? What are some of the benefits and risks of the vaccine? So that's the science portion of this. Next slide, please, Chris. Next would be the ethics of this, and this is where there's a lot of attention spent on looking at the ideas of risk and harm, the ideas of justice. How do we make sure that we address any health inequities, because there are inherent inequities into the delivery of public health and healthcare, and importantly, just the idea of promoting transparency. And then the next slide, the third arm of this triangle is the implementation. So here's where it's really important, because there are two factors to consider. One is, what is the value of the target group receiving the vaccine? And probably more importantly, how feasible is it to administer that vaccine? So is there infrastructure in place to deliver that? All the things that Dr. Raymond mentioned. So these are the factors that go into, how do we start to implement vaccine? Next slide, please. So the ACIP and CDC came out with the 4 criteria. I think everybody's familiar with these right now, so we'll skip this in lieu of time. Next slide, please. This is important just to understand that the sequence of vaccine is not going to be, completing one phase, stopping, and then going to the next, and then stopping until they're complete, and next and next. Really, this is an ongoing process. So we started 1A in the latter part of December, the 3rd week of December, and it will really be a fluid process as we transition over to phase 2. And of course, this is going to be dependent on supply of vaccine into the state. Next slide, please. So Dr. Raymond mentioned the SDMAC. So this is the Advisory Committee for Disaster. So this is stood up whenever there's a declaration of a public health crisis in a state. So we report to we're appointed by the Secretary appointee of the DHS, and our role really is to provide ethics and policy recommendations to DHS, specifically when there are issues of resource constraints like vaccine and therapeutics and other things. So I think while we all understand the bar for 1A is fairly easy, healthcare providers and residents in long-term care facilities. And the reason those two groups were selected as the highest tier is, of course, they have the highest risk of contacting or contracting COVID, and they are also directly patient-facing. And then the largest number of deaths disproportionately have been in populations of nursing homes and those kinds of things. So it made sense through using that triangle and the ethical framework to focus on that as the 1A population. But the 1B now is when it becomes tricky. And this is an example of how the SDMAC translates the CDC guidelines into what's applicable to the state of Wisconsin. So the next slide, please. Thank you. So, these are the recommendations for 1B that were reviewed by the SDMAC. As a matter of fact, we finished this morning, and it will go out to public comment by the end of the afternoon today. And essentially, so we've translated, the federal guidelines are 75 and above, but our recommendations were 70 because in the state of Wisconsin, about 30% of the deaths occurred in patients that were 70 in that gap, 70, 75. So we felt like this was a disproportionate risk to those patients. So anybody 70 and above will be a candidate for vaccine in 1B. Next are the congregate living centers. So these are basically, from mental health institutions to other kinds of settings where there are groups of people living together. And this does include prisons. And then the third category are going to be other essential workers. And now here's where it's tricky because, of course, at one point or another, all of us in the economy are essential to someone. But so using sort of that three-legged triangle in some of the ethical frameworks, how do we try to understand who really is the most at risk to contract COVID, and what do those roles do in serving the larger infrastructure of our population? So here, basically, non-EMS related first responders, those in the school systems, both teachers and support staff, other frontline healthcare personnel, and interestingly enough, in Wisconsin, mink husbandry. And the reason for this, of course, gets to the high risk of gene mutation that's been demonstrated in mink populations. So trying to manage the biosecurity risk of that push this group into the higher infrastructure for Wisconsin. This represents about 1.01 million people in Wisconsin. Now, you might argue there's a lot of other infrastructure groups, and I certainly agree with that. But if we were to look at the 16 categories that are identified by CISA, which is to the right, that brings that population in Wisconsin to about 4 million people that would be eligible for vaccine. And if you look at the numbers, and as we talked about supply chain, there's just not enough to go. So this is sort of the phasing for how we will approach vaccine distribution for this next group. Next slide, please.
So Dr. Colella, let me just interject a couple of questions for you here. One question is, and a really challenging task for you all to balance who gets the vaccine when. But one question that's popped up here is why wouldn't teachers be in the first group? I mean, one of the biggest challenges we have in the community, of course, is kids out of school and how difficult it has been to educate on a virtual basis. So can you respond to that question?
Yeah, I think the reason that teachers weren't in the 1A category is, I think when you're trying to size up using, again, that triangle, while they certainly are at risk of exposure, it can be a risk that's mitigated early on in the pandemic. So the idea is that if you're an ER physician or an intensive care unit nurse or a paramedic, you really can't mitigate that risk. You are really directly facing a patient. Where a teacher, if you were to, restrict class size or keep kids at home for a period of time, you're able to manage that risk. Not to say that it's not important, and they certainly get risk, and that's why they are in the 1B category. But it was just felt like it was not the highest level. That was from the federal recommendations down through the state as well.
Now, another question for you is kind of just thinking about this vaccine distribution. The question is, why can't we use the same kind of distribution system, infrastructure, public-private partnerships that we use for the flu, pneumonia, and other things?
So I think this is really going to be the strategy moving forward. If we look at the feasibility model as an example, I think the feasibility issue and all the requirements around Pfizer, which was the first vaccine delivered, the infrastructure needed to keep that safe to be able to administer it. So just the cold storage as an example, very few places can do that. And really, right or wrong, healthcare systems were the first recipients because they were where the providers were most, and they had the infrastructure to be able to do that. But we will not be able to move forward without a public health and private model for the distributions moving forward. And that's what we're seeing right now. Even as early as 1B, we'll be moving into that model because the health systems are going to be really not primarily in that role. We have to look at other institutions to be able to provide that vaccine.
Thank you.
Yep. And so here's an example of how our community is pivoting. So, I think Dr. Raymond mentioned sort of the fragmented public health delivery we have in the country and in the state. We're a home rule state, so that even complicates things more. So, trying to be able to align resource with people who want the vaccine, there's a lot of moving pieces to it. So, so I have to commend the efforts of the Unified EOC out of Milwaukee, where they're essentially have created this website. It will actually go officially live on Thursday, but you can look at it. It's up and running now. And this is a nice connector for people that are vaccinator programs and phase 1A recipients who may not have been able to be vaccinated. So these are the unaffiliated providers. So things like EMS providers, dentists in the community, et cetera, that don't belong to a health system. This is a way to connect them to vaccine. And my prediction is that we're going to have to move in a model similar to this as we go into 1B and 1C, because I just don't think there's enough capacity, for one agency to do it, for one community. Mm-hmm. Next slide, please. And so I guess the things that you can do as an employer, I think this is one of the questions. So as I mentioned before, the recommendations from the SDMAC will be put on their website today for public comment. They're up there for a week or 10 days. And the next slide, when we're ready, we'll give you a link to do that. So if you feel like your infrastructure sector is important, please be an advocate for yourself. And we look at that to help shape those guidelines. I would also encourage you to start reaching out to your occupational health providers, your local health systems and public health departments on developing the relationship so that when vaccine is available, you're ready to go. And that sort of carries into the next piece too. It's really the best that you can inform your employees about the vaccine, develop a roster so that when vaccine's available, you can translate that very quickly. And I would also encourage you to incentivize your workforce. I think that incentivization doesn't always mean money, but there could be ways that you incentivize a workforce. And then finally, just continue doing all the things that you're doing now to help manage the risk in your workspace. The next slide will have some resources that you can take a look at your leisure. And I'll turn it back over to you, Tim and Dr. Raymond.
Yeah, maybe just a couple concluding questions for both of you. A lot of discussion about whether employers should mandate this, encourage their employees to do it. Any concerns on your end from the liability risk of doing that?
Well, maybe I'll start. I think since the vaccine is under an emergency use authorization, it might be tricky to require this. And as Dr. Raymond mentioned, this is while it's a new technology for developing this vaccine, the technology has actually been around for quite a while. So I think there probably is not a lot of pressure to make this mandatory, but like we do with influenza, after a little bit of time and experience with it, many employers require flu as a condition of employment. So I think it would be hard to mandate it now, but I would hope that we would encourage it again, because this is an important tool.
This is John.
Sure.
Businesses can mandate administration of this vaccine, even though it's approved under an emergency use authorization. And the EEOC has actually weighed in and said that's okay, but they need to prove business essentiality and significant risk to the employee or the customers. So those are the two bars that need to be jumped over. And as Riccardo said, currently the thinking is that we should strongly encourage, especially since there are plenty of people willing to get the vaccine and it's in short supply right now. I personally at MCW, we made a decision not to make the vaccine mandatory. I've heard criticism from people that said because we're healthcare providers, we of all people should take the vaccine. I understand that. And other people say that, we shouldn't mandate it. As Riccardo said, though, as we have more experience and learn more about the safety of these vaccines, they're probably going to be mandatory in the future if a booster is required, just like MCW requires for the influenza vaccine every year, because we feel that our organization has an obligation to the people that we serve to know that your provider and everyone that works with them has been vaccinated.
Yeah, so you see this potentially, and and maybe it's a bit of speculation, if you're going to travel, if you're going to get an airplane, those kinds of things start to require the proof of vaccination.
They may.
Yeah. So another question, and this goes to, kind of future indicators. We've gone through this whole process with all sorts of gating criteria. The government set it up, companies have set it up for what happens when you move from one phase to the other. So as we start to hopefully see the R value come down and some of the other indicators, will we start to set up kind of new gating criteria that go along the lines of, herd immunity, how many people have the vaccination? And this really gets to a question here about if the number of, if the virus survival rate in Wisconsin is 98.9%, when do you believe the vaccine is going to, do you believe the vaccine is necessary to begin resuming life, business, travel, those types of things?
I'll start. Without the substantial majority of our population being immunized or vaccinated, it'll be difficult for us to return to normal life. We're going to have the risk of a potentially lethal virus being spread mostly when people don't feel symptoms. So it's a silent, stealthy killer. And so this herd immunity is really the way that we can squelch the spread of that virus.
I think the other parts too, is while we focus on mortality, certainly that gets everybody's attention. There is some morbidity along with this, as well as the impact of cost and the economic impact. So, I think we should think about all of these things, not just death. So I think it will be a while before we're going to be at a point where we can go back to normal. And actually, there was one other point too. I think, while the death rate is pretty low, if you were to adjust this based on other demographic groups in the state, it still disproportionately affects people of color and others more than it does Caucasians, even though there are certainly more Caucasians dying now too. So that speaks to the equity piece of this as well, of this disease. So I think it's important that we recognize all this.
And then maybe one last question here. I'll try to make this very practical. It's November. Somebody's thinking about holding an in-person event with, 200 or so people. What indicators would you look at to say it's okay to start hosting in-person events and returning to the workplace? I mean, is it a percentage of the population that's been vaccinated in combination with other factors? But we've had, so many specific gates to go through to get us to this point. What are the gates that we're looking to open to get us out of it? You're on mute, John.
Sorry, I was typing answers and I didn't want everybody to hear the keyboard clicking. It's really difficult to just say there's one or two or three metrics and here are the gates. I think that's one of the things we've learned about COVID-19. And we're even struggling with it at the Medical College of Wisconsin. We have major events that we plan every year, including our commencement, and we're trying to figure out when it makes sense. So I would say when at least 70% of the population has received a vaccine. So, and it could be more than that. I'd love to be pleasantly surprised and have it be less, but it's probably going to be more. When the burden of disease is small in your community, and I don't know exactly what that means, but it certainly needs to be so small that your risk of getting it from an incidental contact with somebody is low, and that it doesn't exceed the capacity of your public health system to do good contact tracing, so that we can do what they were able to do in China, which is do good surveillance, and every time there's an outbreak to quickly intervene. We simply don't have the resources to do that right now because there's so much disease in our communities.
Well, good. I appreciate both of you with the factual and thoughtful answers to questions. And I can just tell by the audience, everybody wants to race ahead to the point when we can resume whatever normal means. And so this is going to continue to be an important topic for us, keeping track of where we are on the vaccinations and moving forward to that goal. So Dr. Colella, thank you very much, not only for this, but for your work on the task force and the difficult decisions that you all are grappling with, and the opportunity that you've offered everybody to provide information to help inform those decisions. And Dr. Raymond, again, I just really appreciate your leadership and also sharing your colleagues. A real treasure for the community to have these thoughtful leaders sharing information with us so we can make better decisions.
Thanks, Tim. Thanks, Riccardo.
Thanks to all, and thanks for everybody for what you do. Have a great day.
Thank you.
Good. And again, if you're signed up for this, you'll continue to get notices. We'll be back next month with another business in Milwaukee. And again, if you want your Dr. Raymond fix, you can tune in at 4:20 this afternoon on WTMJ radio every Tuesday. So have a good rest of the day, everyone.
Thanks, Tim.